All right, let's really get focused. We're about to master hypertensive disorders in pregnancy. And look, this isn't just about acing your exam, it's about becoming that nurse who spots the danger signs before things go sideways. I'm going to give you the high-yield, absolutely must-know info so you can walk onto the floor and into your exams feeling completely confident. Okay, let's jump right in.
First things first, you have to understand why this matters so much. Let this number sink in. According to the CDC, hypertensive disorders were a factor in almost a third of all maternal deaths in the hospital. This is not some minor issue. This is a top-tier killer. And the thing is, it's often preventable. So what you learn right now can literally save lives. That's why we hammer this topic home.
Okay, let's start with a classic exam scenario. You're at the bedside, and your patient tells you, I have this new headache that just won't go away, and I'm seeing spots. Your clinical brain has to ignite, like right now. What is the absolute #1 thing you've got to rule out? Because let me tell you, that isn't just a headache. That's a neurological red flag screaming severe preeclampsia or maybe even something worse.
To answer that question, you need this framework burned into your mind. I call these the deadly three. First up, preeclampsia with severe features. The defining feature? End organ damage. Your priority action? Seizure prophylaxis. Then it can progress to eclampsia. Now we're talking actual seizures. Your job is to stabilize and get ready for delivery. And then you have HELP syndrome. This is a true lab value catastrophe. And again, your priority is to stabilize and deliver. We focus on these three because they are the express lane to a maternal crisis.
So let's break down what I think is the most sneaky of the three, HELP syndrome. And here's the exam trap. It can show up without those crazy high blood pressures. You absolutely have to know this acronym cold.
The H stands for hemolysis. This is literally the destruction of red blood cells. Just picture it, this disease is damaging the tiny blood vessels, and the red blood cells are getting shredded to pieces as they try to squeeze through. Clinically, this leads to anemia and sometimes jaundice.
Next, EL is for elevated liver enzymes. This is your signal that the liver is inflamed and taking a major hit. For your exams, look for AST and ALT that are at least double the normal limit. This liver damage is exactly what's causing that hallmark right upper quadrant pain we'll talk about.
And finally, LP stands for low platelets. The technical term is thrombocytopenia. Basically, the body is using up all its platelets trying to fix that vascular damage. When that platelet count drops below 100,000, your patient is facing a massive risk for serious bleeding. This is a critical safety alert.
Now listen to how kind of vague these symptoms sound. Right upper quadrant pain could be indigestion, right? Nausea and vomiting, feeling unwell. It's so easy for these to get dismissed. But you, as the sharp nurse, have to hear these symptoms in a pregnant patient and immediately think, wait a minute, these are giant red flags for help.
Okay, let's clear this up right now because it's a huge point of confusion. Gestational hypertension versus preeclampsia. They both start with high blood pressure after 20 weeks, yes. But here's the key difference, the one you have to know. Preeclampsia is high BP plus something else. It's either protein in the urine or, and this is the modern definition, it's signs of end organ damage, like that headache, those vision changes, or those wacky labs. Gestational HTN is just the high blood pressure. That's it.
Now let's talk about the numbers that matter. When you see a blood pressure of 140/90 or higher, I want you to think of that as your watch closely number. This is the alarm bell that says, okay, we need to start looking deeper. We need to start investigating for preeclampsia. It's your official entry point.
But this number? Oh, this one is a different beast entirely. A blood pressure of 160/110 or higher is your act now number. This is a hypertensive crisis. This isn't waiting, it's not watching. It's intervening with medication immediately because you are trying to prevent a stroke.
And here's that critical add value again, a platelet count under 100,000. When you see this on a lab report for your pregnant patient with hypertension, your brain has to scream HELP syndrome. It's a flashing red light for severe disease and a huge bleeding risk.
All right, let's move on to our high alert medications. And really, when we talk about this topic, there's one MVP, your #1 player on the field, magnesium sulfate. You have to know this drug inside, outside, and backwards. And here it is. This is the single most important, most tested point about mag sulfate. Why do we give it? We give it because it's a central nervous system depressant. Its whole purpose is to prevent seizures or treat them if they happen. It is not an antihypertensive. Now, sure, it might bring the blood pressure down a little as a side effect, but that is not why we give it. That is a classic NCLEX trap.
Now, because MAG is a CNS depressant, it can become toxic, and you have to know the signs of toxicity in this exact order. The very first sign, your canary in the coal mine, is the loss of deep tendon reflexes. Next, if the level keeps rising, you'll see respiratory depression. And finally, the worst-case scenario is cardiac arrest. So what do you do if you suspect toxicity? You stop the MAG immediately, and you give the antidote. And that antidote is calcium gluconate. This is one of those facts you just burn into your brain. No hesitation, you should always know where to find it on your unit, period.
So for that act now blood pressure, you're going to reach for one of these three main drugs. You've got labetalol, a beta blocker, but the huge nursing alert is you never give it to a patient with asthma. Then there's hydralazine, a vasodilator, so you have to watch them like a hawk for a sudden drop in blood pressure. And finally, nifedipine, a calcium channel blocker. Watch out for a headache and a jump in heart rate. These are your go-to meds in an emergency.
Okay, we've covered the knowledge. Now let's see if you can apply it. This is what nursing is all about, prioritization. You've got 4 patients. Who do you lay eyes on first? This question right here tests if you can spot the deadliest situation in the room.
Okay, let's look at our lineup. Patient A, gestational hypertension, BP is in that watch closely range. She's stable for the moment. Patient B, on MAG, reflexes are a little sluggish at 1+, but they're there. You're going to monitor her, but she's not crashing. Patient C reports that new right upper quadrant pain and nausea. Her BP isn't even in the severe range. Notice that. And patient D has preeclampsia with a mild headache. So, who's the sickest?
The answer, and it's not even close, is patient C. That combination of right upper quadrant pain and nausea is screaming HELP syndrome. It points to severe liver involvement. She could be on the verge of a liver rupture or a massive bleed, even without that 160/110 blood pressure. She is your #1 priority, and that is a perfect example of clinical judgment.
All right, let's lock this knowledge in. If you walk away with just 5 things, let it be these. 1. Preeclampsia isn't just high BP. It's high BP plus end organ damage. 2. HELP syndrome can sneak up on you without severe hypertension. That right upper quadrant pain is your big clue. 3. Magnesium sulfate is for the brain, for seizure prevention, not for blood pressure. 4. The antidote for MAG toxicity is calcium gluconate. Know where it is. And 5. A persistent headache is a neurological red flag until proven otherwise. Do not ignore it.
So, we'll wrap up with this. You know the danger signs now. You know the textbook definitions, but the real work begins at the bedside. So how are you going to use this knowledge to advocate for your patient when her symptoms are subtle, when she just says she feels off? Because being able to connect those subtle dots, that's the difference between a good nurse and a great one. That's how you'll save a life.